we can move on to Dr. Mahesh Kumar, the head of Neuro-Ophthalmology Department from Arvind Eye Care. He's going to talk on optic neuritis, how you investigate and manage.
Good afternoon. I thank the organizers for having invited me here. I'll be speaking on optic neuritis and overview of diagnosis and management. So we'll start with the case presentation with a young woman presenting with one-day history of decreased vision in the left eye associated with pain worsened on eye movements. The visual acuity in the left eye was 6/60 with a decreased color vision and a relative afferent pupillary defect. There is a central scotoma in the left eye with normal optic disc in both eyes. So presumptively, we make a diagnosis of an acute retrobulbar optic neuritis. And any retrobulbar neuritis, presumed optic neuritis, should always undergo a neuroimaging, ideally with a MRI scan of the brain. And in this case, this patient had certain classic findings, which are called as which are hyper-intense lesions perpendicular to the perpendicular to the ventricles. You can see these are all called Dawson's fingers, finger-like projections, and periventricular lesions, which are hyper-intense. And also there are some lesions, as Dr. Naveen Jaikmar sir showed, there are some lesions, scattered lesions in the spinal cord, which is suggestive of multiple sclerosis. But remember, these spinal cord lesions need not always be present, and this classic multiple sclerosis has these sort of Dawson finger-like pictures and hyperintense lesions. So what the original optic neuritis treatment trial said, which was conducted 25 years back, they said that the visual outcome of the acute optic neuritis is usually excellent with or without treatment. And high-dose IV steroids, they said that it accelerated the visual recovery but did not affect the final outcome. But there has been so many modifications since then, and we no longer have to follow the typical optic neuritis treatment trial, and we need to understand what is typical and what is atypical optic neuritis. So whatever we have seen so far is a typical optic neuritis, and whatever is atypical is age more than 45 years, but not necessarily more than 45 years. It can also be less than that. If it is bilateral and simultaneous optic neuritis in both eyes, pain may be absent, and disc edema may be present in both eyes. And the clinical course in the case of a typical optic neuritis is described as spontaneously recovering after 3 weeks. But in this case, atypical, it may not recover within 3 weeks of onset, and after 30 days, it may still not improve and even worsen with treatment or without treatment. So this condition of atypical may be steroid dependent or steroid sensitive. For example, steroid dependent in the sense that once we withdraw the steroids, these patients can go down again, and steroid sensitive meaning that these patients can have a sudden visual recovery with just 1 or 2 doses of IV methylprednisolone, dramatically recovering, and we should be very suspicious of these conditions that they may recur again. These are all highly suspicious for recurring optic neuritis. And in these conditions, workup may reveal other systemic conditions apart from multiple sclerosis. So we'll go to the next case, which may be typical of which may show a atypical optic neuritis. This is a young female with a decreased vision of both eyes of 1 week duration. She also had a burning sensation in both the lower limbs and a straining micturition. So the visual acuity is light perception in both eyes with the mid-dilated sluggish pupils in both eyes because of the optic nerve involvement, and there is a bilateral optic disc edema in both eyes. You can note that this disc edema is not florid disc edema, it is a just mild degree of disc edema, which is less likely to be a papilledema, as well as the fact that the visual acuities have gone down acutely also will make us to think a diagnosis other than papilledema, and in this case, it's an optic neuritis. This patient also had a exaggerated deep tenon reflexes. These tenon reflexes were examined because of the paraplegia she had and the straining micturition. So she had this enhanced deep tenon reflexes. And in this MRI scan, this is a normal MRI scan, which again was showed in the first presentation. You can see the central optic nerve surrounded by the CSF. This is a typical T2 fat suppressed image. This is a normal optic nerve sequence in a coronal section. You can see here this central nerve is replaced by an hyperintense lesion throughout, which means it's an hyperintense intensity of the optic nerve suggestive of an acute optic neuritis in both the sides. And in this case, the MRI also showed what Dr. Naveen Jaikmar showed, a longitudinally extensive optic spinal cord involvement suggestive of a diagnosis of neuromyelitis optica or a DeVick's disease. So this is, as of now, we have these biomarkers of neuromyelitis optica antibodies, which we'll be seeing. So typical optic neuritis can fall into a typical clinically isolated syndrome or a multiple sclerosis, whereas atypical optic neuritis, which we just saw, could fall into a neuromyelitis optica spectrum disorder, which can be aquaporin 4 antibodies, which are water channel proteins, antibodies against this in the brain tissue, and antibodies against these are called neuromyelitis optica spectrum disorders, and myelin oligodendrocyte associated antibodies, which is called as MOGAD disease. So there are also other autoantibody mediated disorders like anti-glial fibrillary acidic proteins. These antibodies also have been described, as well as newer antibodies against which biomarkers have not been available as yet in India. So there are certain typical neuroimaging features which can make us suspect, apart from the clinical findings which we have discussed. These neuroimaging features can make us suspect that these could be atypical optic neuritis, like extensive optic nerve involvement, more than 50% of involvement of the optic nerve, and more posteriorly involvement, and more chiasmal involvement of the optic, chiasmal involvement of the neuritis. All these can suggest that possibly this is an atypical optic neuritis, suggestive of a neuromyelitis optica spectrum disorders. This is a very classical description, illustration, showing the different types. In multiple sclerosis, we can see a small segment of the optic nerve which is being involved, and scattered, it may involve scattered spinal cord involvement. In neuromyelitis optica, it can be unilateral or bilateral, more posterior segment, more posterior optic nerve involvement, and possibly a chiasmal involvement also, and this extensive longitudinal segment involvement, as well as other locations where these antibodies are concentrated in the brain and the brainstem. And this is for MOG antibodies. It can be more anterior location, and these spinal cord involvement can be more caudal. So as far as the treatment is concerned, typically we have to treat them with IV methylprednisolone for 3 to 5 days. 5 days is preferable. We can no longer follow the original ONTT treatment trial. We cannot afford not to treat them with any steroids. And if it is severe, if it is not improving within 2 days or so, we should consider referring to a neurologist for possible plasma exchange, and along with immunomodulators like IV rituximabs. And once these patients have recovered, we should always slow steroid taper to avoid a recurrence. And we should await the lab reports. And with seropositive neuromyelitis optica, we should consider immunosuppression with the help of a neurologist. Thank you very much for your attention.